Today's video, we're going to early post-op hip labral repair physical therapy. Get it? Over the top, good work, nice. All right, so early stage physical therapy after hip labral repair is going to be very important. If we do it appropriately, it sets us up great for long-term success. And the other piece is if we do things poorly, sometimes we end up hurting the patients, and that's no bueno. I remember when I graduated from PT school, we barely learned about FAI, and then when I had my first hip labral repair patient, I had no idea what to do. Now obviously this is very, scary as a new grad, so in today's video, we're gonna talk you through what's important to do, what's important not to do. One of the most important things that you should be doing is getting a post-op report from your patient, as well as a protocol, because we have to know specifically which surgery was performed. Believe it or not, a lot of patients have no idea what happened, and what occurred during the surgery is gonna be important. Was there a microfracture procedure? Was there a cane reduction? Did they repair the labrum? Did they have some sort of capsular closure? All these things are going to influence what you do from a PT perspective. The other part is a protocol. We need to know what's okay from a surgeon standpoint of what we can do early on and what we can't do. If you don't have access to these early on, I would definitely ask. So talk to the patient, talk to the MA. If you can, reach out to the surgeon, ask for the post-op report, and ask for the protocol. And I really, really recommend that you don't extend beyond what the surgeon wants from a protocol perspective. A couple things can happen. So A, you might hurt the patient. You might not know what actually occurred during the surgery, and the surgeon wants to limit something for that reason. The other piece is you're going to destroy the network with that surgeon. They're never going to refer patients back to you after that. The other piece is you get into medical legal issues. So make sure that you get a protocol, you follow it. If you feel very strongly there's something on the protocol you disagree with that's going to hurt the patient or keep them from long-term success, reach out to the doctor and communicate. So in this video, we're gonna speak specifically to the first 3 weeks after hip labral repair. We're gonna be taking recommendations from a study from Hanish et al. In 2023. What's up guys, my name is Dan Pope. I'm a physical therapist and a strength coach. We've helped to make thousands of incredible coaches and clinicians through online courses, mentoring programs, and communities. The goal of today's video is to make you 1% better. And before we get going, I just want you to know this is not medical advice. This is going to be for educational purposes and bad entertainment. So if you have a question about your particular surgery, make sure you reach out to the doctor, listen to the physician, listen to your physical therapist. Okay, so a couple things about this surgery before we proceed. Most folks have a labral tear, end up getting the labrum repaired, and they'll usually shave down any sort of cam morphology or pincer morphology within the hip. And when they do this surgery, the large majority of labral tears are going to be the anterior superior portion of the joint. So that means that when the labrum tears, it's in the front top part of the joint. So when they do surgery, they go through the anterior portion of the joint and repair that labrum. And because of that, we have contraindicated motions to allow the front portion of the joint to calm down. So we think about the arthrokinematics of the hip joint. If I go into hip extension, if I go into hip external rotation and abduction, that's going to stretch the front portion of the hip joint. So early on, you're gonna see restrictions from hip extension, range of motion perspective, hip external rotation, and abduction.
Hey there, Broseph McJoseph. I hope you like treats, evidence-based treats, that is. It's an evidence-based cheat sheet for diagnosing and treating femoral acetabular impingement. Now, not everybody loves searing hip pain right through the front of the hip as much as I do. And if you want to make any money as a physical therapist, you're gonna have to help patients with this type of hip pain. Trouble is, gotta stay up to date on this condition to know how to treat it properly. And that's where I come in. With this handy dandy little cheat sheet, we'll catch you up to date on the medical literature on femoral acetabular impingement syndrome in under 10 minutes. We go over a lot of good stuff. Definitions, prevalence, incidence, population, anatomy, risk factors, pathophysiology, mechanism of injury, clinical examination, differential diagnosis, and treatments like physical therapy, injections, and surgery. Best of all, this is a free download. I'll leave a link in the description. Go ahead and download it and get your learn on. And now back to this video.
All right, so in terms of most protocols, it's gonna change from surgeon to surgeon, but usually you're gonna have a limitation of about 20 degrees of abduction out here. Some surgeons don't want any external rotation, so 0 degrees of external rotation, meaning that we can't go here whatsoever. A lot of surgeons are okay with 20 to 30 degrees of external rotation. And the last one is going to be 0 degrees of extension. So your patient is laying on their back or they're laying on their stomach, they're at 0 degrees. I just wouldn't aggressively stretch the front of the hip in the first 3 weeks or so. Again, listen to that protocol. The second group of ranges of motion that are going to be contraindicated early on are going to be deeper degrees of hip flexion and also hip internal rotation. And the reason why is because when we go into hip flexion and internal rotation, we engage that old cam that they shaved down and or that pincer. So we don't want to try to irritate the hip joint by going to end range flexion or internal rotation early on. That can be really provocative. So in terms of how much hip flexion is allowed, some of the local surgeons I like, they limit to about 90 degrees. You will find some papers that limit to about 120 degrees up through here. In terms of internal rotation range of motion, some protocols have a restriction, some don't. Some of the local surgeons I like, they limit to about 20 degrees of internal rotation early on. But you'll find, particularly in that Hanish study, that they want the physical therapist to be a little more aggressive into internal rotation range of motion so your patient doesn't lose range. The other piece to keep in mind is that when they do a hip labral repair, particularly with the cam reduction or the pincer reduction, you end up gaining more range of motion because people's range of motion is oftentimes blocked by a bony limitation, and they just remove that. So I don't think you have to be aggressive with range of motion for these patients. Usually it comes back over time. We don't have to be aggressive early on. If you are aggressive early on, sometimes leaves the patient even more painful, which is also not good. One of the best ways to work on restoring rotation range of motion is simply by log rolling. So what I'll do as a therapist, take my hand above the kneecap. You can also steer the ship a little bit with the patient's foot. And what I'm gonna do is go into internal rotation and external rotation. Just keep in mind the protocol restrictions. If you have a patient that's not allowed to go into external rotation, and this is the end right here, you just go back and forth into internal rotation range of motion. Just keep in mind, some protocols are gonna allow a little bit of range, not too much, right? So just don't go too crazy. The second one we're gonna talk about is gonna be hip flexion. So, if someone has FAI, right, so essentially they haven't had hip labral repair yet, it hurts to go into flexion because you're engaging the cam lesion or the cam morphology into the acetabulum. If I go into a little bit of external rotation abduction, it clears some space, so patients go a little further, generally speaking. Now this is going to hold true after you've had hip labral repair. To steal a term I learned from Mike Ryman, if we go into slight external rotation and abduction, this is more the acetabular plane where we have some more range. And what's nice is that patients usually feel a little bit better out in this range as opposed to going straight ahead into straight plane flexion. And as your patient improves over the course of time, yeah, you can go more into straight plane flexion, but I think early on you're gonna have a little bit more success, you go a little wider. The next thing to focus on is something called circumduction. So largely we're just bringing the leg up and drawing small circles. Now the reason why we consider doing circumduction is because we have a bit of research that shows that when we do circumduction, it reduces the amount of adhesions in the hip. And one of the biggest reasons for hip revision surgery is because of these adhesions. So if we do this 3 to 4 times a day over the next 2 to 3 weeks, and then once a day over the next 10, that can reduce those adhesions. And essentially to do it, it's pretty basic. The patient's just gonna relax as much as they can. I'll usually try to just get them relaxed by shaking the leg a little bit, make sure they're not fighting me. Relax, 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 great. We're gonna go up to about 60 to 70 degrees of flexion. From here, I'm gonna draw 30 small circles. I'm gonna go clockwise and counterclockwise, okay? Kind of a pain in the butt for the physical therapist as well as the caregivers, but usually during the first visit, I'll educate the patient's caregivers, usually the parents or a spouse, and we'll try to have the spouse perform this 3 to 4 times a day, right? If a patient cannot perform the circumduction, the local surgeons I like will actually ask them to get on the stationary bike and just passively spin a little bit more for those reasons. We're trying to reduce adhesions early on after surgery, and that's why I do so much range of motion. Next thing that's important is called tummy time. So essentially you have your patient lay on their belly. When your patient lays on their belly, it extends their hip. And we're not going beyond 0 degrees, so it's really important is you don't prop up onto your hands and do like a cobra or a press up. We don't want that. That's too much range of motion at the hip. But early on, just laying on your belly is gonna get the hip to neutral. What we don't wanna have happen is that the front of the hip gets particularly stiff. So most surgeons' protocols want to see patients do somewhere between 1 or 2 hours of tummy time each day. Now, tummy time is very boring for your patients, but it's also a tremendous time to go check out the Fitness Pain-Free channel. So handing the phone to the patient, they're gonna click on all the videos, you're gonna like, maybe comment a little bit, subscribe. You'll laugh, you'll cry, you'll have a great time. Okay, so the Hanish paper recommended performing soft tissue mobility. They recommended focusing on the TFL, the psoas, adductors, as well as the QL. I think you can also make the argument that you work any structure that's A, either irritated, or B, limits range of motion. So I actually work on the posterior hip because I'm trying to increase flexion range of motion as well, right? So here are a couple techniques you can try. So the first one is gonna be for the TFL. TFL is actually pretty easy to find. So you find your ASIS, go straight down, and basically lateral of the ASIS is going to be the TFL. So it's this big beefy muscle right through this area here. So a couple things I can do. So one, I can take my fingers and press into it, and I can just do a cross friction massage. Now, what's really important to understand is that early on, your patient's gonna have portal holes right in this area. And oftentimes they're in a bandage if you get them close enough from surgery. So I wouldn't be doing these techniques right away. Just make sure that your patient's healed up and you have the okay from your doctor when you can start with these, right? But anyway, straight over top of TFL, over top of it, cross friction massage as so. This is typically a little bit more irritating than performing some general massage on the area. So what you can do is take a little bit of lotion through here. And I like to use my fist. What I do is I take my fist and I roll it up the quad until I get to that TFL, just like so. Now early on, like I said, there's gonna be some portal holes here. So what you can do is just cut your range of motion as soon as you get right to that bandage, and they come right back down again, right? If we're interested in trying to hit the psoas is going to be more medial. So if we feel for the ASIS right here, and then go directly down, the muscle that comes off here is gonna be your sartorius, which comes and it branches on the inside of the knee. If we want to hit the psoas directly, we just go directly medial of the sartorius, and we go below or inferior to the inguinal canal right in this area. So what we can do is we can work directly on the psoas tendon. Again, this can be a little bit provocative. I'm going to cross friction massage right over top of it. We can also try to hit the psoas a little bit higher up. So right here is this ASIS. If I go directly medial to this, and I have the patient take a nice deep breath in, blow out, relax, I can stick my fingers directly into the psoas as well as the obliques. We're probably hitting some intestines in this position too. But go ahead, another breath in, blow out. Every time the patient exhales, they just go a little bit deeper. And when I get to the very bottom here, I can draw some small circles in this position. I can just hold some ischemic compression. And as the patient is starting to tolerate some more active hip contractions, which we'll talk about why we don't want to do these early on, we can actually have them lift their leg, and as they exhale, perform a heel slide. And I'm going to pin down the tissues here. And as the patient exhales, he's going to reach his heel down the table. And in theory, he's lengthening his psoas by reaching the heel. And I'm pressing down to the psoas at the same time. Next, we'll hit the adductors. One of my favorite ways to hit the adductors is with handlebar. So from here, get some lotion on the patient's leg. We want to make sure they're not into end range external rotation. Again, this is contraindicated. Some patients are only allowed to be at 0. So what I do is I sit next to the patient, I block their legs so they can't fall out. Then I take the handlebar right here with some lotion, and I work the adductors up and down, right? The patient says one area is a little more irritated than the other, I'll spend a little bit more time there. The other thing you can do, which is usually tolerated a bit better, if the patient doesn't like the tool because it's too aggravating, you can just use your fist. So essentially what I'll do is I'll take my fist, I'll just run them down the adductors just like so, and again, just target whatever feels most stiff and limited for that patient. Next, we'll talk about the QL. QL is an interesting muscle because it attaches up here on your iliac crest. It comes all the way up to the ribs here and comes down through this area. So basically, pretty much right here, you can see, right? So a couple ways we can tackle this. So we can put a little bit of lotion on this area. And first, I'll talk about positioning, sorry. So I'll have Joe on his side here. And what you'll notice is that first we bring his knees up here, and then we'll take the top side knee down. So you have to be careful because we're going into adduction. So if the patient's not tolerating this or it's contraindicated, don't put your patient into this position. But if I drop this top side leg down, then what happens is that it's going to open up this area, allow me to access the muscle more easily. So I'll take my fist, and essentially I'm going over the top of the iliac crest and just up towards the ribs here. Just keep in mind that if you're starting to rail on someone's ribs, that doesn't feel good. So use light pressure and ask questions about how intense it feels for the patient. Usually I like to keep that pain below about a 5 out of 10, right? The second thing we can do is we can go directly at the muscle with our fingertips. And what I like to do is use a towel, because a towel is going to help my fingers stick a little bit. If I go directly on someone's skin, I'm gonna roll on the skin, and my fingernails might get into the patient, so that's not good, right? So I'm gonna cover up the patient's back with the towel, and from here I'm gonna find the area that I wanna work on, and I can draw some small circles on that area. I can also hold some ischemic compression right through here. The other thing I can mess around with is I can have Joe do some anterior and posterior pelvic tilts. Let's go ahead and tilt your pelvis. Yep, and then we'll tilt back the other way. Let's go back and forth. I want to show you a few repetitions without the towel. So if I pin down the tissue in the QL and have the patient perform posterior pelvic tilt, anterior pelvic tilt, you can see how we're sliding those tissues, stretching those tissues as we put some pressure directly down. Just make sure you're not violating any sort of contraindications. I don't have Joe's leg way up into flexion, right? We don't want to aggravate the patient. So just make sure you ask a lot of questions. It is a fresh post-op patient. They can't be twisting themselves into pretzels early on. I also like to do a little soft tissue work to the back side of the hip. This can be nice if the patient is particularly sore back there, or if they're limited to flexion or rotation range of motion. So essentially I take my hands and go over here and feel for the greater trochanter. And if I come just superior to that, I know I'm the glute medius. And if I go a little bit posterior to that and superior at the same time, I'm gonna go along the border of the glute medius. And what I can do is a cross friction massage over top of this, which tends to feel pretty decent for your patients. If I want to try to target, let's say the piriformis, I go back and I find my bony prominences, right? So greater trochanter, I feel for the sacrum, and essentially the piriformis is going to be between those 2 points, right? So if I want to go on that, again, I can do a little bit of a cross friction massage over top of that muscle group. If I want to hit the deep hip rotators, I just need to find the back portion of the femur. So again, greater trochanter, and then deep down to that are my deep hip rotators all the way down. So if I want to be specific about targeting those, I can go straight over those muscles, right? Another technique I like to do, and be careful with these post-op patients because they're going to be restricted with range of motion, is to do a little pin and stretch, right? So this always confuses me, but if I take the leg out wide this way, that's internal rotation. If I go this way, that's external rotation. So keep in mind, your patients that aren't allowed to externally rotate, this is no bueno. We can't do this, right? Or if your surgeon doesn't want to allow them internal rotation, we can't crank here. But essentially, I can take Joe's hip, put him into a little bit of external rotation, and I can pin down the deep hip rotators through here, pin them down, and then stretch them by going into internal rotation, right? Just like so. If I want to get a little more pressure, I can take my elbow and do the same thing. So essentially, find the muscles I want to target, press down on them, and I go into some internal rotation. Relax on the pressure, externally rotate, put some pressure down, internally rotate. So pin and stretch. All right, so next we'll talk about strength. And when I say strength, it's not really strength. We're focusing on a little bit of active assist range of motion, maybe some isometrics, working our way towards active range of motion over the course of time. The first area we have to be very careful with is going to be the hip flexors. So a lot of protocols don't want you to do any sort of active hip flexor work until 2 to 3 weeks. The reason being is if we're too aggressive with our hip flexor exercises, we can get this out of control tendonitis, and it really sets the patient back. So essentially, you want to educate the patient about this early on, make sure they're not rolling out of bed by picking their leg up straight towards the ceiling. Fortunately, it's a little bit painful in the beginning, so if patients accidentally kind of go through that contraindication, they'll know it, and they'll stop hopefully in the future. So if you guys are interested in some early stage exercises, they're all based around EMG of the hip flexors, I'll leave a link in the show notes of my favorite exercises, as well as ranking exercise from low EMG to high EMG. In terms of strengthening the rest of the muscles around the hip, generally speaking, we want to start with isometrics, progress our way to active assist range of motion, and follow up with active range of motion. You just have to be very careful about your protocol restrictions with your patient. If you have a patient that's not allowed to go into any sort of external rotation, I can't do clamshells, right? So just use your brain. In terms of working the muscles around the hip, we can work isometric external rotation simply by taking my hand, put it on the patient's knee, go ahead and press against me about 10 to 20% of your max, and then relax. Do keep in mind the isometrics are usually considered easy, but if we have Joe push as hard as he can against me isometrically, that's really, really too much for a fresh post-op patient. Just make sure they're not pressing too aggressively, right? If we want to start to work on our hip internal rotators, we can take a ball, put this between the knees from here. What I want you to do is just press up into my hand while squeezing this ball. So give me a squeeze and then push up to the ceiling. Good, 10 to 20% of your max, and go ahead and take a breather, right? In order to work abduction, we can very easily just have Joe straighten out his leg, and from here, lightly go ahead and push up into my resistance, and then relax, right? Once your patient is allowed to do a little bit of external rotation, we can start working to a clamshell. For patients that don't have this contraindication early on, we can start that a little bit sooner. So from here, keep your hips stacked up. Usually I'll take my hand and put it towards basically a target height, because I don't want Joe going all the way up to about, 45 to 60 degrees of external rotation. So I'll put my hand here, go ahead and try to hit my hand. If the patient's having a really tough time with this, I'll assist them a little bit. Go ahead and push up. Yep, so a little bit active assist range of motion. You can do the same exact thing for internal rotation range of motion. So go ahead and give me a squeeze here. I want you to lift your heel up towards the ceiling and then right back down again. So again, I might give them a target to make sure they're not going too high, right? They need a little lift, I'll help them out just like that, okay? The next motion we're gonna work is going to be abduction. I like to start this off with a short lever. So tricked you, Joe. Let's bend this knee right here. So the more I bend the knee, the easier this is for my hip abductors. I will start with this short lever with the leg bent. So from here, what I want you to do, Joe, is to lift the knee and the heel simultaneously up towards the ceiling and then right back down again. So if we're limited with abduction, we want to make sure you're not going too high, right? And over the course of time, as this is tolerated well, I'll remove any sort of assistance. So go ahead a few on your own there for me, Joe. Yep. And as Joe gets even stronger, we can just straighten out the whole leg and do a regular abduction with the leg straight. Next, we'll talk a little about the adductors as well as the core. So largely, we want to make sure that we are working the core somewhat. We can do this just by bracing the core. So what I'll do is, let's go ahead and put your legs down for now, Joe. And I'll take my fingers and I'll go right below the ribs, right into this area, and come over towards the middle of the belly on the side, just like this. Go ahead and brace like I'm gonna punch in the belly. And I'll just feel and make sure that I can't put my fingers into the area. And that just allows me to know that he's probably got a pretty decent core contraction, right? So the first exercise we'll do is a core contraction with a ball squeeze. So we're combining a little bit of isometric core, a little bit of isometric adductor. So we'll take a ball, put it between the legs, go ahead and brace for me. I'll take my fingers and try to poke them into the belly and squeeze this lightly, 10 to 20% of your max. Usually do this for repetitions, so a 1 or 2 second squeeze, perform 8 to 10 times, right? Once the patient's doing well with this, we can move our way on to more active range of motion or active assist range of motion. So what we're gonna do here, Joe, is contract with your core, and then let this knee come out towards me a little bit. Good, and then pull right back. So this is a bent knee fallout, and if need be, I can assist a little bit, or if Joe's doing really good, then I can let him go on his own. Just make sure that your patient's not going into end range external rotation, because that's contraindicated, early on. We can also work a little bit of hip extension. Just keep in mind, when you do a quadruped position like this for a bird dog, you are weight bearing on the hip. So some protocols will include this in early stage rehab, but if you're not supposed to be putting weight through this hip in this position, I wouldn't do that, right? If you have questions, consult the surgeon. So in this position, what we can do is we can extend one hip straight back. Just go ahead and kick back to the wall and then right back again. So if you're limited in terms of your contraindications for flexion and extension, if you have your patient reach back towards the wall, go ahead and reach for me, right? We're not going beyond neutral at the hip. A decent way to start working on hip extension as well. Next, I just want to talk a little bit about weight bearing as well as using crutches. So largely, you're going to see restrictions between 2 and 3 weeks for a standard hip labral repair, where you're not allowed to weight bear on this quite yet, but you will see some newer protocols that are allowing people to weight bear a little bit sooner. So make sure you talk to your surgeon. The other piece, if there is a microfracture procedure along with a hip labral repair, then usually they're limiting weight bearing for around 6 weeks. So all the more reason to get a post-op report and know what the heck is going on, right? The other piece is going to be foot flat weight bearing over toe touch weight bearing. Can you show me toe touch weight bearing right now here, Joe? Very good. So in toe touch weight bearing, there's a couple things going on. For one, Joe is kind of lifting his own hip a little bit. And when he does this, we're activating the hip flexors. We just talked about how we don't want to have the hip flexors be that active. So when we go to a foot flat weight bearing, now all of a sudden he can relax his hip a little bit more so. The other piece is that when Joe is in foot flat weight bearing, stay up nice and tall for me, he's extended at the hip. Now go into toe touch again, he's flexed at the hip. And one of the things we're trying to promote is mobility of the hip flexors. So if we go foot flat, we actually extend the hip a little bit. The other piece is that when we're in toe touch weight bearing, we're going to be a little bit of plantar flexion. When we have the heel all the way down, we're getting a little bit of stretch of the calves. So we're trying to maintain mobility as much as possible. And the last piece is when you go into toe touch weight bearing, go and pick up your leg, you're actively using the muscles around the hip, right? Which puts strain on the surgical repair somewhat. The other piece is that when you pick up your leg a little bit, there are distraction forces. So as soon as you pick up your leg, the ball is trying to pull out of the socket slightly. If we put 20% of your weight into this leg, now we reduce those distraction forces, we relax all the muscles around the hip. All right, so now you know the principles behind rehab after post-op hip labral repair. Now you might want to see the specifics. So I have a case study of a former patient of mine, and I did a video documenting how we did exact care. And what we're gonna do is leave that video up in the corner. Go ahead and click on that. I'll see you in that video, and we'll keep up the learning.